Hi again, everyone. My name is Cleaver. I'll be walking you through the second portion of the eFAST exam. Last portion was the pericardial or subxiphoid view. Hopefully you've been able to review that well. And this one, we're going to go ahead and move towards the lungs, okay? And this is called the anterior thoracic, aka lung view, okay? So again, this is the 2 out of the 5, although be sure with this one that you'll check both the left and the right lung to make sure if there's any signs of problems such as a pneumothorax, which we'll get into later. And then after this, I believe Dr. Goodmurphy and my other colleagues will go ahead and talk about the rest of the 3 views of the eFAST exam, okay? So similar to the subxiphoid or the pericardial view, I'm a very big picture type of person, and I like to have like these cartoon drawings so that we kind of know what we're dealing with and then what we'll try to find when we're on the ultrasound machine, okay? So here you'll kind of see on this right-hand side, let me go ahead and pull up the pointer, here that there is the rib cages, and it also shows the intercostal muscles, and then as you peel that back or reflect that back, you kind of see the lungs. The lungs do have a similar pericardial sac, but instead is called a pleural sac. So again, almost the lungs as well have like a similar water balloon or Ziploc bag that again should have a minute amount of fluid so that the lungs expand and breathe and then they exhale and shrink so that there's not too much friction in that as well, okay? The problem is that instead of too much fluid coming into the pleural sac this time, problematically is that there could be air within the pleural sac. Oh, I apologize. There could be air that comes into that, and then that could restrict it as well. Okay, but again, there is a pleural sac. There is the parietal pleura, and then the visceral pleura, and there should be around 10 cc's of serous fluids in there. So when we talk about the ultrasound, we're talking about probe placement. The probe placement, in contrast, would be the midclavicular line. So you can imagine a clavicle going right here. You go half that clavicle, and then they say by textbook, it should be the 3rd or 4th intercostal ribs. So you count your ribs, 1, 2, 3, 4. So between here is your 3rd, and between here is your 4, okay? So you put the probe here. Again, as Dr. Goodmurphy has probably mentioned, the probe indicator should always be towards the patient's right or towards their head. And as we practice this in person, you'll find out that you're supposed to put your probe placement, probe indicator towards the patient's head. 3rd and 4th is textbook, but again, everybody comes in different shapes and sizes, so you may have to move up or down accordingly. What's not imaged in this one is like a nipple. So I sometimes like to use the nipple as like an indicator. You kind of just go around that area in between the ribs, okay? Here's that pleural sac. I talk about that pleural sac often because this is going to be one of the key landmark features on the ultrasound as we kind of look at ultrasound images. So just keep that in mind. And we'll have the patient laying supine. Most likely they'll be laying down. So I kind of try to twist this in a way so it would be imitating a patient. And so as they're laying down and you kind of look for the 3rd or 4th intercostal ribs, you'll go ahead and place a probe indicator here. And then that will show us exactly what we're trying to find. And notice how when I put the probe here, you're going to hit some ribs. So like kind of what we did the subxiphoid view, and you're not just looking at the heart, but you kind of saw some liver, maybe some abdominal muscle, maybe some stomach. And this one, you're not going to, don't expect to just see lung. You're going to see some structures such as maybe some ribs, some intercostal muscles, and then finally the lung as it kind of goes deeper, okay? So let's go ahead and move on. And here's a cartoon drawing of a pleural sac again. Just to reiterate, we have a visceral pleura closest to the lungs and a parietal pleura away from the lungs, and then in between that there's a pleural sac with a little bit of fluid just to lubricate the lungs as it's kind of breathing up and down, okay? Pleural effusions are possible as you kind of have fluid buildup, similar to our last module, but for the eFAST examination, we're not necessarily looking for pleural effusions this time, but more so we're looking for has air escaped within this sac. So instead of fluid, we're looking for air, okay? And that air does not look as clean as it does on ultrasound, but we'll get to that in a second. So here we have images of what a pneumothorax may look like, whether that be closed, that most likely from like a blunt trauma, or an open pneumothorax, whether that be like from a penetrating trauma. But nonetheless, the lungs can have surrounding air around it within the sac, and that can compress the lungs. Sometimes it can be so compressive that it shifts the lungs and it leads to a tension pneumo. But nonetheless, this is what we're looking for, and let's go ahead and see what a normal ultrasound looks like. A normal ultrasound looks like for this. That way we can contrast that to a abnormal, a problematic ultrasound when there is a tension pneumo or a pneumothorax, okay? So this right here, let's try to orientate ourselves. This is a normal anterior thoracic or lung ultrasound. I will always show you normal, so you have a normal library bank in the back of your head before we look at abnormal. This one is not as intuitive as you can see the heart. In the last one, you really can't shape out what exactly is a lung. And the lung is a big structure, so your tiny or your relatively small ultrasound probe won't capture the whole entire lung, but you may see aspects of it, okay? So here we have, I didn't draw a probe this time because I think we're kind of getting it now that the probe is here, right? Whatever superficial structure is closest to the probe will show at the top, and as you kind of go deeper, it'll be away from the probe, okay? So you can see some skin layers here. You can see some hypoechoic, muscle layers here as you kind of have like some maybe pectoralis muscle going on. And then you have some shapes here. And if you're able to intuitively or like think about and try to figure out what these two shapes may be, I've tried to highlight that in the previous slides. And here it is. So imagine those shapes being the rib cages right here. So again, we're going to get some ribs as we get the ultrasound beam coming down, okay? We're going to get some ribs. This rib should be the more superior one. So let's say if this is like the third rib and then this is the fourth rib, this would be the third intercostal space because the indicator should always be pointing towards the patient's head, right? So this is a rib and then this is a rib, okay? Which I've highlighted here, okay? Let's just try to figure out what normal is. And then underneath here is maybe that Dr. Goodmurphy has mentioned it, but the ribs are super, super hard, super, super strong. And as your sound waves of your ultrasound machine kind of hits the ribs, it can't go past the ribs because of how dense it is. So here we call it rib shadowing artifact, right? So the ribs are so dense that when the sound waves hits downwards towards your ribs, it really cannot pick up anything past it. So it leaves a little shadow, okay? So this is important because as we kind of think about anechoic, fluid structures, this is not a problematic feature. This is a normal feature. And now let's look at this pleural line, okay? So this line right here is the pleural line, and that's consisting of the parietal pleura. You can separate it between the pleural line and the lung line, but I think that's kind of out of scope here. Just know that this is kind of where we see the very most edge of the lung, okay? And then everything underneath that is the lung, okay? So you have to identify, you should be able to identify the ribs, rib shadowing artifact, and in between the ribs, you'll see the edge, the pleura, the pleural sac of the lungs. This is very classic, again, it should be very minute. And then sometimes you'll be able to see some intercostal muscles in between the ribs, right? Let me go ahead and highlight the pleural line here. And so this combination between the ribs and this pleural line, some sonographers, ultrasound professionals may call this the bat sign. It takes a little bit of imagination to imagine a bat, but nonetheless, if you look up, bat sign ultrasound, this will show up. Okay, and as we have the lung is filled with air, as the ultrasound kind of comes downwards and hits the pleural line, it's going to hit air waves after it. Okay, so it hits nothing underneath the ribs because the ribs are so dense. But it hits the lungs, and because there's air waves or air within the lungs, it leads to reverberation artifacts. So these are called A-lines artifacts. And again, these are completely normal. Okay, and they say they should have the same spacing throughout. All right. So a lot going on, but now we know ribs, rib shadowing artifacts, pleural line, that pleural sac, and then the A-line artifacts because there's air in the lungs and this kind of leading to reverberation. So let's go ahead and take a look at this image over here. Again, try to orientate yourself. This is zoomed in. So this is zoomed in showing only one rib, if you're able to see that. But before that, let's go ahead and look at skin, subcutaneous fat, some maybe intercostal or some pectoralis muscle, and then some intercostal muscle here, okay? So now you should be able, hopefully you're picking this up as we kind of see a rib and then the shadowing underneath. And then see if you can see the pleural line before I go ahead and jump to it. And that's the pleural line. So now I highlight this fact because there's one more artifact that's kind of a key feature when you're looking at lung ultrasound, okay? So instead of reverberation artifacts kind of going sideways, you also have B lines, which is a different type of artifact. Right here, if you're able to see it right there. So B line, aka a comet tail artifact, is right there, and that is also indicative of a normal anterior thoracic ultrasound. A little tidbit is that even with a pneumothorax and there's air buildup and there's a lung collapse, you will be able to still see A-line artifacts, but B lines are specific to normal ultrasound, okay? So let's go ahead and look at a normal, what they say. So the main goal of a lung ultrasound, right, for our purposes and for the curriculum is that are you able to identify the key structures and key artifacts within the ultrasound, right, within a lung ultrasound. But clinically as well, are you able to identify what they call a lung sliding sign? And lung sliding is because when you have that little lubricant within the pleural sac and your lungs kind of inspire and expire, you should be able to see some lung movement, okay? In contrast, when you have a pneumothorax and you have air and you have that pressure again, similar to the heart, when you have pressure, your lungs won't be able to inspire and expire and will kind of stay stuck, okay? So let's go ahead and look at what a normal lung sliding looks like. And pay attention to, the ribs, as you can see the ribs here, orientate yourself to ribs here, and the pleural line. And see if you can see the B line or the comet tail and the movement of that. Right there. So as your lungs inspire and expire, it moves these artifacts, showing well lubrication, showing well inspire and expiration, okay? Versus, let's go ahead and see if this is absent, okay? So this is an absent lung sliding on the right here. And notice there's no great effusion, there's no great air, anatomical air that you can see here, but what you should be able to see is that the lung is stagnant, okay? So again, let's orientate ourselves. This is the rib, right? This is the rib. Maybe there's another rib right here. This is intercostal muscle, right? And this is the pleural line, okay? Now see if you can see B lines and that lung movement that you kind of saw here that was a little bit shimmering, and if you can't see it here. So no B lines, you can actually see it trying to struggle a little bit. You can see some muscles here moving, but you can see some struggling here, okay? And again, this is in a standard ultrasound. What they have now is B mode that gives very crisp images, but it takes a couple practices. It's a little bit minute, but as we kind of practice on each other and practice on each other in person, this will get a little bit more familiar, okay? But even if you're not able to see this, you can put your ultrasound into what they call M mode or motion mode, which we'll get into the next slide. So now we'll talk about the M mode or motion mode tool essentially on the ultrasound. That way, if you're not able to visualize and interpret real-time B lines or lung sliding sign during your lung ultrasound, you can always press the M mode option, and we'll dive into that here as you see your normal ultrasound picture up top with the bat sign view again. But really, we're going to look at this aspect right here, this portion. And what this is that from top to bottom, this relays information from top to bottom. And it kind of takes the average of whatever motion that may or may not be on screen and kind of throws it into this schematic right here. So anything that's kind of stagnant on your initial ultrasound, stagnant, not moving, will kind of project itself as a horizontal line here, okay? And anything that there is movement will create noise. And that noise is then projected as kind of like the stippling image right here. So you can assume that, or you can interpret that your skin, your musculoskeletal layers, and your bones won't be moving. So therefore, it would be projected as this stagnant horizontal lines here, reflecting this stagnant horizontal movement here. Versus when your lungs of this aspect is inspiring and expiring and moving up and down, breathing in and out, is going to create a lot of noise. And that noise is going to lead to this stippling image here. And that's what some ultrasounds sonographers or clinicians kind of call it as a seashore sign. So you ever read the literature, you see some seashore sign, they're kind of talking about a normal lung sliding sign in M mode. Okay, so again, the stagnant skin, musculoskeletal layer, and bones, ribs are kind of stagnant, while your lungs are inspiring and expiring, kind of looks stippling, right? In contrast, when there's a pneumothorax and there's pressure and the lungs are having problems or having difficulties with inspiring and expiring, then there won't be any motion at all within your lungs, right? Because it's kind of at a standstill spot because of the pressure. So therefore, all the stagnation that you kind of see, the horizontal lines here, will then carry throughout the entire image, okay? So you see the stippling on the left side, again, normal lung sliding signs as you inspire and expire, it creates noise, versus over here, it cannot detect any motion whatsoever, and therefore is a generalized, diffused horizontal lines. And so this is called the barcode sign, okay? There's no image of a barcode, but you can imagine that this looks like a barcode sign, while this one looks like a seashore sign on the left. And again, this barcode sign is pneumothorax or absent lung sliding sign, okay? So if you're not able to see it real time, just go ahead and flip it into M mode or motion mode, and then you should be able to see and interpret the two different images that we have here. All right? And that's about it. Okay, so just a recap, are you able to identify the key structures and artifacts on this lung view ultrasound? And then are you able to recognize real-time lung sliding, the real-time lung sliding sign, and try to follow the B tail or the comet tail artifact? If not, are you able to recognize the seashore sign, which is normal, versus a barcode sign on M mode? Again, we'll practice all these three things as we kind of practice in-person scanning. And all of this is to say, you know, that we can intervene if necessary, and this is beyond the scope of this curriculum. But you can use this real-time data to say, do we need to tap it? Do we need to let the air out? Do we need to aspirate it with a needle decompression? Or will this spontaneously resolve on its own, okay? So these are real implications after we kind of learn the basics. Just want to say thank you so much, and thanks for tuning in. I think Dr. Goodmurphy is going to catch you on the next one, but again, feel free to email any of us for any questions. My name is Cleaver, and hope you have a great day, okay?